This is the recording to accompany the slides, drugs of the CNS. In the peripheral nervous system, within the autonomic nervous system, there's only three main neurotransmitters. That is acetylcholine, norepinephrine, and epinephrine. However, in the central nervous system, there are over 21 different neurotransmitters. Some of it are listed over here. We won't talk about all 21 of them, but I'll talk about a few of them within the context of some common clinical conditions. Now, what I'm going to do is I'm going to try to explain briefly the clinical condition and then how drugs work to actually revert that or to manage that clinical condition that I'm talking about. But just briefly, in terms of drugs of the central nervous system, they are drugs that act on the brain and in the spinal cord, because that's what the central nervous system is made of. And so one of the things that needs to happen is that the drug needs to actually cross the blood-brain barrier. In most cases, when drugs are given orally or IV, unless they're given directly into the spinal, the spinal space, they actually have to cross the blood-brain barrier. So some medical uses for drugs that actually do manage to cross the blood-brain barrier are pain relief here, production of anesthesia, and treatment of psychiatric disorders and seizures. So we're going to look at psychiatric disorders in a different lecture. Some non-medical uses for drugs that do cross the blood-brain barrier are to use as a stimulant, as a depressant, to make a person feel euphoric, and for other sort of mind-altering abilities. And this is where we get into drugs that produce addiction or dependency and so on. As I said, the blood-brain barrier is there to actually prevent most drugs from going in. So if you look at the diagram down below, that's a blood-brain barrier over here. And what you can see here is that lipid-soluble drugs, as indicated by the orange circle, can actually go straight through the blood-brain barrier, whereas hydrophilic drugs, water-soluble drugs, can't actually go through. They have to actually use transport systems in order for it to actually go enter into the central nervous system. And so what it means is that this blood-brain barrier is effective in stopping most toxins from entering the central nervous system, but also it's difficult because drugs need to have certain properties in order for it to actually be able to enter into the brain, and we'll see that in a little bit. Understanding psychotherapeutic drugs, like I said, we're going to talk about that in a later lecture. But in terms of psychotherapeutic drugs, it's really hard to figure out what's going on in the brain. It's not like we can actually take a snapshot or take a biopsy of the brain to try to figure out what's going on. And also mental health is a very complex issue. To actually make it more complicated, to actually develop drugs that are used to treat or manage psychiatric disorders, it's very hard to test them on animals because we don't really have a good animal model for schizophrenia, for depression, you get what I mean, right? So it's really hard to actually figure out whether the drugs will work without actually testing it on a patient population. Of course, with drugs that are used to treat psychotherapeutic disorders, it's really hard to actually test them on mentally healthy individuals, right? So that's a whole nother ball game, and it's as I said, the development of drugs to treat these neuropsychiatric disorders are sort of advancing slowly, a little bit at a time, rather than having big leaps in therapeutic breakthroughs. One of the things that happens is that sometimes drugs that affect the CNS actually have different effects when the drug is taken over a period of weeks or months versus the effects of the drug when taken initially. And so what we see happen sometimes is that the therapeutic effects will increase over time, but it has to be taken for several weeks before those effects are fully felt. And also, if the drugs have side effects, some of those side effects decrease over time. And so what happens is there's this kind of funny thing where the side effects decrease over time and the therapeutic effects increase over time, right? And so an example is that morphine that crosses the blood-brain barrier to have analgesic effects, sometimes initially would cause nausea and constipation. But if a person is on morphine for a while, then the nausea diminishes, the constipation diminishes, but the analgesic effect persists. We're going to talk about tolerance and dependence later on in the lecture. So we're going to move on to our first central nervous system disorder, and that's Alzheimer's. So again, just a word of reminder that anything with a background means that it's background information, good to know, but you're not going to be tested directly on it. So Alzheimer's disease is a condition that's devastating. Most of us know someone directly or indirectly that has suffered or is suffering with this condition. And what happens is that someone can actually develop Alzheimer's and live a normal length of life, but obviously the quality of life will be much diminished. So what they think happen with Alzheimer's disease is that neurons die. And the neurons that die tend to be those in the hippocampus that are involved in memory, and cerebral cortex that are involved in speech, perception, reasoning, and higher order functions. And what happens is, because neurons die, the sheer volume of brain matter actually also decreases. One of the big things that happens in Alzheimer's disease is we know that the levels of the neurotransmitter acetylcholine decreases over time. In severe Alzheimer's, some people have been shown to have only 10% of the normal levels of acetylcholine. And acetylcholine is a very important neurotransmitter in the brain, and it's critical. It has been shown to forming memories. So what happens with this is a couple of things. So there are beta amyloid proteins that sort of clump, and they develop into what's called plaques over here. So instead of it being nice and clear like you see in the diagram above in the normal brain, what happens is these beta amyloid proteins clump up and they develop these plaques, right? Most of us do have beta amyloid protein, but because they are recognized as being abnormal in people without Alzheimer's, they are immediately taken apart and disbanded, right? So our levels of beta amyloid protein are fairly low most of the time. So that's one thing. So the plaques actually form clumps. The other thing that happens is, if you look at the normal brain, what you can see over here is that there are microtubules that start from the cell body over here down to the nerve ending on the right side. And one of the purposes of the microtubule in a nerve fiber is to actually transport neurotransmitters that are synthesized in the cell body all the way down to the nerve ending, right? So acetylcholine, like a lot of other transmitters, is made in the cell body, and what happens is it gets packaged into those vesicles, and those vesicles need to be transported down the axon in order for it to go and reach the nerve ending so that it can be released. In people with Alzheimer's disease, however, those microtubules form these tangles. So instead of having nice straight lines, right, they form these tangles, and so the acetylcholine that's produced in the cell body cannot actually be transported down the axon, and therefore acetylcholine cannot be released, right? And so what happens is the level of acetylcholine decreases quite substantially, right? We know the typical symptoms of people living with Alzheimer's disease. That's memory loss, personality change, difficulty with self-care, and also depression is also one of the big neuropsychiatric disorders that accompany people with Alzheimer's. Inability to recognize family members or to communicate is one of the big ones, and that's when the person in body is still there, but their mind just isn't the way it used to be. So Alzheimer's disease at the moment cannot be cured, so the goal of treatment is management, right? So what we want to do is we want to improve symptoms, and we want to reverse or slow down cognitive decline, right? So at the moment we cannot reverse cognitive decline, we can only slow it down, right? So and the way that it does it is through this mechanism. So you see the diagram on the right. What you see is that you see acetylcholine being made in the cell body of the nerve, and it's packaged into vesicles and then released, and then acetylcholine binds to cholinergic receptors, and then at some point there's this enzyme acetylcholinesterase that actually breaks down acetylcholine into its component acetate and choline. So one of the big things, one of the big current treatments of Alzheimer's disease is to actually inhibit this enzyme. So if you inhibit this enzyme, even though the amount of acetylcholine released is decreased in Alzheimer's disease, what happens is because this enzyme is inhibited, then acetylcholine in the synaptic cleft actually remains there for longer, right? So it enhances the it kind of slows down the symptoms associated with Alzheimer's disease. It does not stop the progression of the disease, but it delays or slows it. The problem with acetylcholine is we cannot give it, right? We cannot give it because it gets broken down very, very quickly. So one of the strategies for this is to actually stop its breakdown. And so there's certain drugs that actually do that, right? So that's good. So the amount of acetylcholine in the synaptic cleft in the CNS actually stays around, and you have less of that cognitive decline and all that kind of stuff. The problem is then it doesn't just work in the CNS. So these drugs that stop acetylcholine from breaking down also stop acetylcholine from breaking down throughout the body in the peripheral nervous system as well. And so it's like giving someone a big jolt of acetylcholine, and so you see the cholinergic effects, right? Acetylcholine in the respiratory tract causes bronchoconstriction in the cardiovascular tract, causes bradycardia. It's related to fainting, fall-related fractures, right? And acetylcholine is also the predominant neurotransmitter that's involved in digestive functioning. And so what happens is it has gastrointestinal effects, and those are listed over here. All right, so it's not without its side effect, but it does help to slow down cognitive decline in terms of the person's ability to look after themselves, to recognize people, and all that kind of thing. The other strategy for managing Alzheimer's disease is to give a glutamate receptor antagonist. So glutamate, let's see, hang on. Glutamate is an excitatory neurotransmitter in the CNS that can also cause neurotoxicity if there's too much floating around. Glutamate acts on the NMDA receptor. And so what happens is if you give an antagonist to block the effects of glutamate, then it actually reduces the death or the toxicity to the neurons, right? So again, that's another strategy to stop neurons from dying. Glutamate receptor antagonists are often given, and they are, for the most part, better tolerated than cholinesterase inhibitors, but they do have some side effects as well. The third group of drugs that are given to manage Alzheimer's disease are drugs to manage the neuropsychiatric symptoms. So some people develop sort of psychosis, and so these are the drugs that are sometimes used to treat that aspect of people living with Alzheimer's disease. And we'll talk about that in the antipsychotic lecture. The next condition is epilepsy. So epilepsy, when epilepsy occurs, what happens is some neurons in the CNS have excessive excitability, right? So instead of firing when stimulated, they fire all the time, right? So you've got a whole host of action potentials, as you can see in this diagram over here. And so what happens is when those neurons are hyperexcited, they can develop, it can cause the person to develop symptoms from brief periods of unconsciousness to violent convulsions, right? And the seizures are what actually tell people that a person's having an epileptic fit or an epileptic seizure. If epilepsy develops in a younger child, it can cause problems with learning, memory, and mood. And so what happens is one of the big things to actually deal with epilepsy is to try to figure out what causes that hyperexcitability of the neurons, right? And so the drugs used to actually manage epilepsy work to reduce seizures to a level that allows patients to live a normal life as possible and balance the desire for complete seizure control with acceptable side effects. And so here you've got, again, therapeutic versus adverse effects, right? No drug is completely safe. Most drugs have got side effects, so it's actually how to manage the side effects while actually allowing the drugs to have a therapeutic effect. So one of the big things with anti-epileptic drugs or anticonvulsant drugs is to actually stop the discharge of those neurons within the central nervous system, which have that hyperexcitability, right? So one of the things to actually do that, I'm going to draw a neuron over here, is this. So you've got several different strategies over here. So what happens is calcium is needed to enter into the cell in order for neurotransmitters to be released, right? So calcium needs to enter into the cell body in order to actually drive neurotransmitter release. So if you suppress that, then you suppress neurotransmitter release. If you suppress neurotransmitter release, then the neuron isn't excitable. The same with sodium. So sodium is one of those ions that neurotransmitters bind to the receptors to open the iron pore. And so again, if you prevent the influx of sodium, then it prevents action potential being generated in the second neuron, right? The third strategy is to antagonize excitatory neurotransmitter glutamate. So again, glutamate is a neurotransmitter found in the CNS, and what happens when glutamate is released is it excites the neuron. So in order to stop excitation of the neurons, let's put a brake on it. Let's antagonize it. Let's block the effect of glutamate. So that's a third strategy. And then the fourth strategy is to increase the effect of GABA. So GABA is an inhibitory neurotransmitter. So GABA is like a brake, right? Whereas glutamate is like putting your foot on the accelerator pedal. So basically what you want to do in the system is you want to put the brakes on by increasing the effect of GABA, and you want to take your foot of the accelerator by blocking the effects of glutamate. All right, and so in the next slide, you see some drugs that are commonly used that use those strategies. So the first three drugs, phenytoin, carbamazepine, and valproic acid, basically blocks the sodium ion channel. And so sodium can't go in and can't perpetuate an action potential in seizure generating neurons, right? Valproic acid over here also has the added mechanism of action of inhibiting calcium going into the neurons, as well as increasing the inhibitory effect of the inhibitory neurotransmitters GABA. Phenobarbital, the fourth drug here, actually just works to increase the inhibitory effect of GABA. And so you see over here, that's how it works in the first row. In the second row, you see what it's used for. So carbamazepine is used for, so all four drugs are used to manage epilepsy. Carbamazepine and valproic acid are used to manage bipolar disorder as well. And if you look at the adverse effects, you've got some neurologic effect of phenytoin, including sedation, cognitive impairment. Same with carbamazepine. Valproic acid has got some gastrointestinal effect, which actually make it really hard to convince someone to actually take that drug. And then it's got teratogenic effects, can cause pancreatitis and liver failure as well. So and then phenobarbital depresses the central nervous system, and so it can lead to quite severe depression, CNS depression, causing lethargy, fatigue, tiredness, and all that kind of stuff. All right? So you can see that none of these drugs are necessarily pleasant drugs to take, but with someone who's living with epilepsy and epileptic seizures, it's a trade-off, right, between being able to actually live normally versus having to live with the unpredictability of seizures at any given time. And then with the drug interactions, you see over here that a lot of the drug interactions, so with phenytoin, it decreases the effect of drugs that are also plasma protein bound, because phenytoin also is bound to protein, and it also increases the levels of some other drugs. With carbamazepine, you can see here that the drug interactions are two of the other drugs in this slide. And so basically what you want to avoid is you want to avoid someone taking full doses of carbamazepine with phenytoin and phenobarbital, because that then reduces the activity of neurons to probably to a level where the person's function is not really viable, right? So it leads to some side effects that way. And if you look over here as well, in the other with valproic acid, that also is one of the drug interactions, two of the other drugs on this page. And again, with phenobarbital, it's there as well, right? So you don't need to memorize these drug interactions, just to understand why they are there. Now, one of the big things with phenytoin, which is the drug of choice for epilepsy, is this. So phenytoin has got a very narrow dose range for its therapeutic range, right? So most drugs, you've got a minimum effective dose over here, and a dose over here where you start developing toxic effects. Whereas with phenytoin, so the therapeutic dose range of most drugs is actually fairly large. Whereas with phenytoin, look at how narrow it is, right? It only ranges from here to here because it needs to get this to this level before it starts becoming effective. But when it gets to not very much higher than that, it starts developing toxic effects. And then the other thing with phenytoin is that the amount of drug that actually ends up in the plasma varies between different individuals. So the graph on the right basically shows you 5 individuals who've been given doses of phenytoin, and you can see here how the amount of drug that ends up in the plasma varies between the 5 individuals, right? So anything above the yellow line means that it reaches toxic levels, right? Anything below means it's not effective over here, anything below the yellow line. And so you need that therapeutic range to be in the person's plasma, and it's very hard to actually try to get that. And so regular blood testing of the levels of phenytoin is needed to ensure that the dose of the drug stays within the therapeutic range and doesn't go either above or below it. Next condition is muscle spasms and spasticity. So again, just to differentiate between what spasticity is. Spasticity is so both of them look the same, but spasticity, the origin of spasticity is within the central nervous system, whereas muscle spasms is caused by localized skeletal muscle injury, right? So how you treat them will also differ. So there's 3 different strategies to actually handle spasticity. The first one is baclofen. So baclofen acts the same way as GABA. So remember, GABA is an inhibitory neurotransmitters. And so with spasticity, similar to epilepsy, you want to quieten down portions of the CNS. And so to actually quieten down portions of the CNS, you put the brake on, right? You put the brakes on, you increase the effects of GABA. And that's what baclofen does. And so you've got over here the therapeutic uses for baclofen. And at the moment, there's, in terms of the adverse effects, unfortunately, at the moment, there's no antidote for an overdose of baclofen. And because it works in the CNS, it can take a while for it to be effective. And you need to actually withdraw it. If a person stops taking baclofen, they need to stop taking it over a period of 1 to 2 weeks rather than an abrupt cessation of therapy. The next drug is diazepam, which works almost the same way as phenobarbital in the previous slide, because it imitates the effect of GABA. Again, GABA inhibitory neurotransmitters, so it acts to break those neurons that are hyperactive, right? As is the case in spasticity, right? So diazepam is the only one labeled to treat spasticity, but because it inhibits the CNS, it also can cause sedation, and that's one of the uses for Valium as for people as an anti-anxiety medication for people who can't sleep, need help sleeping, and so diazepam is sometimes prescribed to help people sleep. And then the third drug is dantrolene. So this one acts directly on this muscle, skeletal muscle itself. It inhibits calcium release from calcitonin. So if you look at the table at the diagram in the bottom, so you see here how calcium here is released from these organelles. So these small organelles, the orange sort of ovals, are actually sarcoplasmic reticulum. They contain calcium, and calcium can be released when a skeletal muscle is activated. But if you stop the release, then basically it stops and inhibits the contraction cycle of skeletal muscle. So it stops muscle spasms. All right, and you can see here down the bottom what dantrolene is used for, and you've got here one of the side effects of dantrolene is muscle weakness, right? Because it stops muscle contraction, sometimes so much that it causes muscle weakness. And then in the CNS, it can end up causing drowsiness, diarrhea, and diarrhea as well. Next group of drugs is local anesthetics. So local anesthetics work by blocking sodium channels, and by doing that, it blocks impulse conduction along the axons. So basically what happens is you got a neuron over here, right? And that neuron releases neurotransmitter on the cell. Neurotransmitter binds to the receptor, and then in some cases what happens is that receptor is linked to an ion channel that allows sodium to go in. Now if that ion channel is blocked, or if that receptor is blocked, what happens is sodium won't be able to enter into the cell, and then nothing happens downstream to that. So it basically just blocks the whole pathway, and it stops pain from the pain sensation from going up to the central nervous system, where we can actually sense that as pain, right? Local anesthetics, because it's applied locally, only affects those neurons near the site of administration, right? So local anesthetic, you can apply too much local anesthetic that it enters into the systemic circulation, but if it's actually administered properly, it does not. So it just causes anesthetic, so it just causes loss of pain sensation on the site around where it's applied, right? So local anesthetics can be applied as a topical anesthetic, over here, or down below as a spray, or it can be injected subcutaneously as well, right? In terms of the duration of action, if it's applied topically or as a nasal spray, it needs to enter into the axon membrane, right? So it depends on on the size of the local anesthetic, lipid solubility, degree of ionization of the drug. And then how long it lasts depends on how quickly blood flows to that area to try to take it away, right? Sometimes what happens is when a local anesthetic is given subcutaneously, it's also given at the same time with epinephrine. So epinephrine is injected along with a local anesthetic, and the reason for that is epinephrine causes vasoconstriction. So it limits the blood flow to that area that the local anesthetic is applied, and so what happens is that the local anesthetic stays for longer. So it decreases local blood flow, and so therefore it stays in that area of administration for longer, delays the movement of the local anesthetic away from that area, so it doesn't get diluted as quickly, and it then prolongs the anesthetic effect, reduces the amount of drug that needs to be applied, and if you reduce the amount of drug that needs to be applied, then you reduce the risk of toxicity as well. As I said, the adverse effects of local anesthetic tend to be when the drug actually enters in a large enough volume into the systemic circulation, and then it affects the central nervous system or affects the nervous system in general throughout the body, right? So adverse effects are a brief period of excitation followed by depression because it depresses the central nervous system. And then in terms of the cardiovascular effect, look at this. It basically just slows down cardiovascular responses. So it causes slow heart rate. Sometimes it reduces the contractile force, and it causes low blood pressure, and it basically just stops it itself, right? And then if you're giving it together with epinephrine, then if again, if you give too much and the epinephrine enters into the systemic circulation, then you can have the effects of what happens when you have too much epinephrine floating around. So that's palpitation, tachycardia, nervousness, hypertension, and so on and so forth, right? So some application guidelines are that it needs to be given in a small as possible dose as needed. Try not to apply it to areas of broken or irritated skin, because what happens is it can enter into the bloodstream right away and not basically stay in the area that it's administered. And then avoid strenuous exercise, because that increases blood flow. And when you increase blood flow, then you dilute the effect a lot quicker. The next lot of drugs that I'm going to to talk about are opioids. So again, opioids are analgesic that are given to relieve pain without loss of consciousness. They're the most effective analgesic, but they come with problems as well. So that's why they're prescription only and all that kind of stuff. So opioid refers to compounds that are present in opium. So I've got here a picture of the opium, or the opium plant. And opioids act on 3 different classes of opioid receptors. So they're the mu, kappa, and delta. And for the purposes of this lecture, we're really focused on the mu opioid receptors, right? So they're the ones that are involved in analgesia, but they also cause respiratory depression, euphoria, sedation, and physical dependence. Opioids are used for post-operative pain, for obstetric pain, cancer-related pain, and chronic non-cancer pain, and also to relieve the pain felt after a heart attack or during a myocardial infarction. Some opioid agonists, what happens is they activate mainly mu opioid receptors with some kappa receptors. So you relieve pain without affecting other senses, right? So no loss of consciousness. You can still see, touch, smell, hear, talk, and all that kind of stuff. But because it also causes euphoria, there's a high liability for abuse, right? Like most other drugs, when given orally, some of it gets metabolized in the liver. So when given orally, the doses are higher than when given IV due to the first pass effect. Some strong opioid agonists are listed over here, and some moderate to strong opioid agonists are listed over here. So the agonists actually stimulate the mu opioid receptor to lead to the effects that I talked about at the top of this slide. Morphine can be administered by several routes. So morphine is a fairly common opioid that's used. So you've got all the different routes of administration over here. It's not very lipid soluble, so it does not cause the blood-brain easily. So basically the dose that is given, not very much actually goes into the brain, but enough obviously goes into the brain to cause the analgesic effects and other effects. So some precautions when administering morphine is that people with decreased respiratory reserve should not be given morphine, because morphine causes respiratory depression, right? So you don't want to decrease what's already lacking there. Pregnancy, labor, and delivery, morphine can get into in through the fetal circulation through the placenta during pregnancy, or can go through into the fetal blood, especially during nursing or breastfeeding. Head injury, again, because it causes severe CNS depression, you don't want to give to people with head injury, and also with infants because their blood-brain barrier is leaky, as well as young kids under the age of 12. You need either smaller doses or just don't give, find another solution for analgesic. Interactions, as I said, because it causes CNS depression, you don't want to give it with other drugs that also cause CNS depression. Anticholinergic drugs, and again with these ones, you don't want to actually exacerbate a problem that's already there, right? So, and again, not to combine with other opioid related drugs in order to actually ensure that the effects of morphine are not diluted by the presence of opioid antagonists or other drugs that act as both agonists and antagonists. Adverse effects are all listed here. You can see there's quite a few of them. The big one is that it has an abuse liability, right? And you've got a classic triad of overdose symptoms, right? So coma, respiratory depression, pinpoint pupils, and respiratory depression is a big one. And then you've got a whole list of other adverse effects, right? So again, it's not a very, it's an effective drug, but it also comes with its toxic or adverse effects. Nursing implication of on opioid drugs, you can see here it's essential to do pain assessment, right? So pain assessment before, pain assessment after, and then that will actually allow dosage determination as well as adjustment depending on how the patient responds to pain. Monitor vital signs, that would be blood pressure and respiratory rate. Identify high-risk patients, so patients with CNS depression, patients who are pregnant, and all that kind of stuff in the previous slides. Avoid withdrawal because that might actually trigger and withdrawal complex, and then also teaching a patient about adverse effects so they can self-monitor, right? So drowsiness, constipation, reduced respiration rate, dry mouth, nausea, and all that kind of stuff. Dependency, tolerance, and withdrawal. So these are just some terms with their definitions over here, right? Tolerance is when a person is used to an amount of a drug to get a certain effect, and basically they end up needing a higher dose to get the same effect. Physical dependence is rare with acute morphine, and that this is very important because some people in the hospital are very wary of taking morphine because they hear that morphine, you can get addicted to morphine, right? But usually it takes a while, right? So it occurs with prolonged drug use, and the amounts of morphine that are given to patients in hospital for post-operative care is very tightly controlled and regulated. And then you've got abuse, what abuse is, what abstinence syndrome is, and addiction here. And then the last slide is on opioid antagonists. So we've heard a lot about Narcan being given as nasal spray to actually combat the influx of people that have taken either knowingly or unknowingly fentanyl, right? And so what happens is naloxone, the drug that's found in Narcan, basically steps in and kicks morphine or fentanyl off the opioid receptor and blocks the effect of the morphine or fentanyl. So it basically reverses the drug overdose and reverses post-operative opioid effects, and if given soon enough, right? So that's the big key. It needs to be given soon enough in order to reverse the effects of the opioid. There's several other opioid antagonists. So naltrexone is used to manage opioid addiction. So basically, doesn't prevents euphoria if the abuser takes an opioid. So it's something that an addict might take, so that even if they do take an opioid, right, if they self-administer an opioid, the opioid can actually kick out naltrexone, right? So they won't actually get that euphoria or the high that they crave when they're taking the opioid. And then methyl naltrexone is used to treat opioid-induced constipation that occurs in the first few weeks of opioid use. So on that note, I'm going to finish up and leave you with another recorded lecture.